Today on the Self-Carapist podcast, we're going to be talking about the collaborative assessment and management of suicidality, or CAMS, with Dr. Jobs. And Dr. David Jobs is a professor of psychology and associate director of clinical training at the Catholic University of America in Washington, D.C., and the director of the CUA Suicide Prevention Lab. He's also an adjunct professor of psychiatry, School of Medicine, Uniformed Services, University of the Health Sciences, and has researched and written and produced over 100 peer-reviewed publications, including 6 books on clinical suicidality. Thank you, Dr. Jobs, for joining us today, and welcome to the Self-Carapist podcast.
Thank you, Lorraine, for having me. I appreciate it.
I appreciate it too. What did I miss in the intro? What else have you been up to?
I've just been at this for a long time, since grad school. So, I've been in the field for over 40 years and have pretty much, I met the founders, knew people all the way through my career. And so I've got sort of a long view perspective on this topic.
Yeah, I think that sounds like a great place to start. What did the beginning of this research that you've poured so much time and energy look like? What started your interest in this subject?
I was actually a lackluster college student trying to get into a PhD program, and had a great time in college, but didn't really do the things that one needs to do to be competitive for a clinical psych PhD program. So long story short, I had to make up ground after I graduated from University of Colorado, and I worked in research, and I worked at a children's hospital for a while, and then I applied and got into a master's program at American University, and all the while trying to accrue those experiences that would make me more competitive. And my psychopathology professor was a person named Lanny Berman, and he was he's not retired, but he was a real luminary in the field back in 1982, and I just got hooked. I got hooked on the topic. I was a philosopher in college, and so the philosophical sort of aspects of suicide were really compelling to me. And then I got involved, and Lanny sort of opened a world to me. I met the founders of the Los Angeles Suicide Prevention Center, and I met Marshall Linehan. I met Aaron Beck and a lot of prominent people that were really generous towards me, and so it was an auspicious and wonderful start, and it's a fairly young field. Really, that we date the start of suicide prevention in the States, late 1950s, early 1960s. And I've been in it for a while.
What were we doing before suicide prevention? What was the take on it before that started?
Oh, I think, really was the sociologists had kind of the corner on the market. Emil Durkheim wrote this very famous book called Les Suicide. It was published in 120 years ago. And they were looking at epidemiology and looking at big numbers and then risk factors. And, for many years, this field has been dominated by a medical model that actually doesn't work. And I can say more about that. But, really thinking of suicide as a symptom of depression, for example. And that, the logic would then be to treat the depression, you reduce suicidal ideation and behavior. And that's actually what the research shows. The research shows that targeting our treatment on ideation and behavior, suicide ideation behavior, is where the action is, independent of diagnosis, Lorraine. So it's been in my lifetime a bit of a shift in focus to a more psychological approach, and yet we're still really, I would say, caught up in actually a medieval mindset that a person that's suicidal should be hospitalized, and that will make them not kill themselves. And then when they come to their senses and we don't need to control them anymore, they will no longer be suicidal. And in many ways, if a modal response is for a person that's suicidal is to get a medication, most medicines don't really help, and some make it worse. And 3 or 4 or 5 day or 10-day hospital stay, they come out actually at higher risk. So it's an interesting struggle that we've got a carceral controlling and validating model that is probably what people think they're supposed to do and must be helpful, which the evidence doesn't really support. And then the interventions that I'm involved with and some others that focus on suicide and keeping somebody out of the hospital has much better empirical support, but the interest in the engagement with those are still lagging.
Yeah. Yeah. It stands out to me that you said in your lifetime that switch has happened because of exactly what you just said, that switch hasn't happened for everyone. A lot of people are still identifying with the first part of what you described.
Well, that's why I'm so grateful to do like a podcast like this with you, Lorraine, is that, it really every time I talk to a journalist or I talk to somebody in the media or a colleague like you, it's just trying to hammer home. We actually do have evidence of things that are effective. The problem is that clinicians aren't using them. And so there's there's a research to practice, I was going to say gap, it's a chasm, that we're struggling to close. Understandably, a lot of it's just like, if I'm a parent and my 13-year-old is thinking about suicide, I just want to do whatever we can to make him not attempt or take their life. And I get that. And yet the irony, even with adolescents, and I can say more about this if you want, if we can support autonomy and developing agency, we have much better outcomes than taking control of this person and trying to perforce make them not be suicidal.
Yeah, that makes a lot of sense. And also, while at the same time, it seems like there's also an isolative property that happens when we take someone out of their environment where they potentially have support. So we're looking at autonomy and also being a member of something. And to your point, it can be inadvertently validating of the thought or the behavior when it feels like their only community is over here inpatient.
Yeah. I mean, it's a rabbit hole of sorts, but really there's very clear research that coming out of the hospital, people are much more at risk. There's new research, for example, scoping review out of Australia, that involuntary commitment actually is much more problematic than it is helpful. It may be helpful with medication compliance, for example.
Sure. Yeah, sure.
But specific to suicide risk, Lorraine, it actually increases the risk. And people are shocked to hear that. They don't, we don't want to hear that. We want to think that we can do something in a 3-day hospital stay, when mostly people just sit around in a day room and watch TV and take medication.
Yeah. Yeah. Without access to anything, their own clothes, their own games, so it's, I can see how it becomes a rabbit hole because there are a lot of pieces that are, I guess overlooked, but maybe even with the best of intentions, like you said, the hope to provide something, it would be great if it worked.
No, I totally, I really want it both ways. I don't want to talk down my nose, and be a smarty pants expert that doesn't get it. I get.
Yeah.
Believe me, after 43 years, I get the desire for people that we care about not to take their life, but it doesn't mean that we should do things that make it worse. And that's, believe it or not, that's a really tough thing to change because it's been around for hundreds of years, if you think about it in a certain kind of way. So, that's why I love talking to people like you. It's really the goal to say, we don't have to throw the baby out with the bathwater, but we can do things that actually are effective. But requires especially clinicians and systems of care to change their mindset. And I would say, in fairness, that it is changing. It's just changing very slowly and incrementally.
Yeah. Dave, can you just sort of start at the beginning and describe how the CAMS approach works, what it entails? Sure.
So CAMS is the Collaborative Assessment Management of Suicidality. So it's a framework. It's not a new psychotherapy. So one good news story for clinicians is that we can embrace or engage people who are psycholytic, people who are humanistic, people who are behavioral. And, we don't tell people how to treat. What we do though, is engage a person who's suicidal in a therapeutic assessment. And by that, I mean, with their permission, if we're doing it live or also online, we literally or figuratively take a seat next to them to go through an assessment tool called the Suicide Status Form. And the patient actually is the person that completes the first page, or the first screen, as it were, and the clinician helps. And what we find is after they engage for 20, 25 minutes on various ratings and written responses, that the patient feels better. And it's because we mostly kind of get it. We sort of understand and can anticipate and even sometimes even complete the sentences of the patients because we really are dialed in to what it means to be suicidal. And then we transition into looking at risk and warning signs to come up with together a treatment plan designed to keep you out of the hospital. Now there are inpatient versions of CAMS where the focus is disposition discharge, but in the standard intervention, it's mostly about trying to work with you on an outpatient basis. And we'll develop a stabilization plan, which is much like the Stanley Brown safety plan or the crisis response plan. It's a tool that's meant to get you through your dark moments. And then the really novel thing, and I kind of chuck every time I say it, and I've been saying it for years, the really novel thing about CAMS is we ask the patient, what makes you suicidal? And they tell us, and that's what we treat. The vast majority, and we call those drivers. So the vast majority of drivers are relational. My kids don't talk to me. My girlfriend dumped me. Very much relationally based. Adolescent is being bullied online. And then the other major drivers are vocational. I hate what I do. I can't get a job. I'm losing my house, because I don't have a job. And then issues of the self. And why all this is important is that, and this is research that really is almost 20 years old, when we really started to learn from people who have experience and from people who are suicidal, what makes them suicidal, they were not saying, my schizophrenia.
Depression, like you were saying earlier, you're not hearing that.
It's not that we never hear that, but we hear much more. My PTSD from combat, in Iraq. The fact that I hate myself, and I can't look myself in the mirror and not feel disgust. Things that are big ticket issues. We had a case of a 10-year-old yesterday in one of our clinical trials who said the brain rot of my generation. So we hear all kinds of things, and it's not like we're going to treat the brain rot of your generation, but we are going to look at your in this case this child's preoccupation with things in the world these days. They're very 10 years old, very preoccupied with our politics and with the toxicity of our culture and the things that are in the news. And we can work on those kinds of things. A lot of times with a lot of the relational things, it'll be couples therapy. We'll send somebody to group. So there are interventions for these drivers. And that's really what the first session of CAMS is a therapeutic assessment, a clear stabilization plan that we want you to use, the identification of 2 problem drivers, and then we'll come up with the interventions that treat those drivers. The thing I would say, Lorraine, that's really striking about that first session, and we watch videos all the time for the clinical trials, is when I tell you I have 4 or 5 different interventions for your self-hate that makes you want to kill yourself, you oftentimes see this this little flicker of kind of and it looks a lot like hope.
Yeah, that's the word I was thinking.
Yeah. So that's how we launch CAMS, and then in the next series of sessions, which we call interim sessions, we check in on the core assessment, those variables that we assessed in the first session, very quickly, and then we spend the rest of the session really focused on those problems. And we update the treatment plan, sharpen up your stabilization plan, and we do that interim care until criteria are met for outcome and disposition. And according to clinical trials, we've got a lot of research and tons of publications. We're talking about 6 to 8 session intervention. And a really big thing, Lorraine, about CAMS is that we don't necessarily eradicate every vestige of suicidal thinking, but we do really establish stability, and we do help a person manage the thoughts and feelings, the suicidal thoughts and feelings. So it's not like we turn off a switch. It's like a rheostat that we turn down. The person feels stable, and they're able to manage the thoughts and feelings. And then the capstone of CAMS is to shift our focus to life worth living, and what would give you a sense of purpose and meaning. And that's sort of CAMS in a nutshell.
Yeah, I'm hearing some of those threads to DBT language as you explain, and I could see how the two could work in synchronously together.
Yeah, very much so. And we have clinics now that are using both interventions. And
Oh, wow.
I can say more about that if you want.
Yeah. Yeah. I would like to hear more about that.
Well, we have clinical trials that NIMH has funded looking at the use of CAMS and DBT and treatment as usual. And that's one big multi-site trial that we did with college students. And the thing about and Marcia Linehan was a research mentor to me, so I very much was influenced by her in the research that we did. But the big thing with DBT, as you probably know, is that it really does, it's the best treatment for reducing attempt behaviors and self-harm. There's nothing that comes even close. And the thing that CAMS does better than any other intervention, just based on the research and what we know, is that it reduces ideation. So we've had now something called the Hope Institute, and there's also CAMS clinics where they're really instituting sort of a combination where maybe everybody starts out with CAMS in the Hope Institute model, and then people who need it and are dysregulated and self-harming will also get DBT skills group added into the mix. And the beauty of it is if we're averting an expensive emergency department stay, which is always a very negative experience pretty much across the board around the world, and we're averting an inpatient stay, we're saving a tremendous amount of money. And as you alluded to, we're not stigmatizing them. They're not getting pulled out of school. They're not getting pulled out of their job, away from their family. We're able to stabilize them in an intensive outpatient model. So that's where a lot of my time is spent these days, is really talking about care transition, aversion models, so we can avoid hospitalization and ED, emergency department stays. And to that end, we have a one-session version of CAMS called CAMS Brief Intervention. That's basically just the first session. And we've got really good data. So it can be used in the emergency department or an inpatient unit. And it's literally a one and done. And we've got now probably half a dozen trials really drilling down on that model, and one publication and another that's pending.
Oh,
it's cool.
I wanted to loop back to the link I made earlier, just if anybody listening isn't familiar with DBT, the thread I mentioned was the life worth living, which is one of the goals of DBT. And then also just the goal of keeping, not sending a client to a higher level of care when you hear that language. And CAMS sounds like the framework that can be applied to help maintain someone in their current level of functioning.
Yeah, we really aspire to a least restrictive level of intervention. And especially, because of the evidence of what inpatient care is. So people hear me talk about this stuff and they think I'm like bashing inpatient psychiatry, and I'm not. I am absolutely critical that suicide-focused things like safety planning or lethal means discussions or caring contact or simple things that we know are effective are not being reliably done. And this is not opinion-based, it's based on research.
Yeah. Regarding that, it seems like there has been mixed evidence or mixed discussions about safety plans and their efficacy recently. What can you say about that?
What I can say is that Barbara Stanley and Greg Brown created a remedy to the no harm contract model, which was Lorraine promising you won't kill yourself between now and Monday, yes or no, and if you refuse, I'll put you in the hospital. So coercive, invalidating, never made sense. It didn't make sense to me when I was a psych tech back in the 80s.
Yeah.
On inpatient, I felt I was embarrassed to actually do no harm contracting. So Barbara Stanley, who passed away a few years ago, and Greg Brown developed this safety plan, which is a 6-step intervention. And they published one excellent cohort comparison trial in JAMA Psychiatry, but it's never had a randomized control trial. And for those that aren't familiar, there's correlational research, which is valuable, and there are randomized control trials, which get into causality. Not really competing because we're all friends and colleagues, but a different intervention is called the crisis response plan. It was developed by David Rudd and further work and studied by Craig Bryan he's now at the University of Vermont. And that has 3 randomized control trials showing its effectiveness. So, and the CAMS stabilization plan is embedded within the treatment. So it's a first cousin of the two. So the safety plan intervention really, in my view, does need a randomized control trial to show its effectiveness. The crisis response plan which is very similar, but it's done on an index card where the patient writes out their triggers and their different coping strategies, and then the resources that they will reach out to if need be, and they laminate and stick it in the person's pocket. I mean, that actually has really good data, but nobody knows about it. So this is not a field that's defined by the evidence, which is frustrating to a person like me, because the Columbia Suicide Severity Rating Scale, or the CSSRS, in my view, is not the best screener. The ASQ is a better screener from the psychometrics and the research that's been published. And that was developed at NIMH by Lisa Horowitz. But the Columbia is like the Band-Aid of the field.
Yeah.
One of my soapbox positions is a Columbia and a safety plan is absolutely better than nothing, and absolutely better than what we used to do. But really, an ASQ and CAMS, or an ASQ, and then a crisis response plan has better evidence. So, we're just trying to get people to do things that we know work at all.
Yeah.
And in my view, it always should be the things that work the best. We're still a little bit of ways on that.
Yeah. You mentioned an evidence problem in our field, but there's also a marketing problem. We've been conditioned to keep things quiet, not speak out about something that can't be proven, and I think that.
Yeah. Well, back in the day, Marcia literally pulled me aside and said, if you ever want clinicians in the wild to use CAMS, you're going to have to develop a business. And that's why dialectical behavior therapy is world famous, is that she founded behavioral technology when she was 25 years ago.
Yeah.
DBT is a really complicated intervention,
yeah.
and yet it's so well known. And that's because there's been a business behind it to get people to use it with adherence.
Yeah, I think that's really important. You had we talked a little bit about drivers and some of the interventions that could be used, for example, with a relational challenge. What are the types of, and you mentioned PTSD, what are the types of interventions, similar, more in-depth treatment plan in therapy?
Yeah, whatever to use.
Yeah.
Really, if it's funny, in Denmark, where CAMS is very popular, they're very psychoanalytically oriented. And so they just 100% rely on insight. So when I'm there and they're showing me a case or something like that, and I'll say, so, behavior activation or cognitive therapy or insight, and they're like, we talk about it. It's actually become like a joke where they feel like if we just talk about the problem, that insight is the key to cure. And they're like, oh, you're so American. You want to fix everything. I was like, yeah, I do. Call me crazy. I like to fix these things that people say consider suicide. So, but that said, they love the intervention. So, that's really, I think, been some of the success that we've had in training, because we do have a business that trains, and we've trained over 50,000 clinicians, which sounds like a lot, but it's a drop in the bucket. When you really think of the grand scheme of things, there are 16.9 million Americans who have serious thoughts of suicide in 2024, and that's a lot of people. So, we really have a huge population of people who are suffering, and a workforce that's not particularly dialed in on what works.
Yeah. How do those 2024 statistics, the 16.9 million, compared to years before? Was it on an uptick after COVID?
Actually, it's interesting. The suicide rate has gone up. It dipped for 2 years right before and during COVID, and then it bounced back up, is level off a little bit this year, but the ideation has just gone up. There's a SAMHSA survey that's published usually in August or September that survived all the cuts that have come, unmediated political, but under the current administration. And so the survey survives. And actually the question is, Lorraine, have you had serious thoughts of suicide in the past 30 days? Yes or no? And that's where we get the 16,900,000 people saying yes. For teenagers, that's come down a bit. For adults, it's bumped up in the most recent data. So to me, it's and the field is very behaviorally focused, which again, I get. We're talking almost about 49,000 suicides, 11th leading cause of death. But I'm preoccupied with this iceberg phenomenon of all the people that are suffering and struggling. And like in the example I always use is in the United Kingdom, where they had the National Health Service, you don't get an evidence-based intervention for being suicidal unless you make an attempt. And if you make an attempt, then you can get DBT. You can get a wait list for DBT. But if you haven't made an attempt and you're suicidal, you get supportive counseling. So effectively, there's a healthcare system that's operantly conditioning people
Yes.
to ramp up to attempt behavior to get actually effective treatment. So those are the kinds of things that make somebody like me crazy, because if we were better at identifying people upstream at this ideational level and treating them there with CAMS or with other interventions that could be effective, you'd have fewer attempts and fewer completions. But we tend not to have that mindset. We tend to have a really, we tend to wait till the crisis.
Yeah.
And we tend not to treat in an upstream kind of way, at least in this part of the field.
Yeah, we're not doing preventative necessarily. We're doing responsive, or
crisis response. And to be sure, crisis response has been transformed in the years that I've been involved, where we now are using safety plan type interventions, which have evidence. We know that lethal means safety discussions can be very powerful and effective to remove access. We certainly know that the lifeline, the 988 number, which is a moonshot. The first time I was at a lifeline discussion, maybe 15 years ago, 12 years ago, and somebody mentioned the idea of a 3-digit number for the lifeline, the room burst out in laughter. No one thought it'd be possible from a policy standpoint. So, it's not that there's no progress, and the 988 number is fantastic. Eddie Gould's research at Columbia has shown it's effective. There's also a national text line, but the Pew Research Foundation did a study several years ago looking at Joint Commission accredited hospitals, and are they doing safety planning adherently? Are they talking about lethal means? Are they using the lifeline number? Are they doing warm handoffs for care transition? And less than 8 or 9% of the hospitals were. So it's not a soapbox position that I'm just like taking shots. We could make our inpatient care much more suicide focused and evidence based, but we're still wedded to a medical model and thinking that a 3-day hospital stay is actually going to be helpful when the only thing basically patients get is is medication or maybe a couple of groups that the research shows. Survey research shows that patients don't like or find helpful, and it's expensive.
Yeah.
So these are the kinds of things that I'm pretty much preoccupied with, because there's a better way to use evidence to use least restrictive interventions, and we'd save money if we did it.
Yeah. Just to recap something you were saying earlier, it sounds like CAMS can be and is just as effective with suicidal ideation without a plan or without an attempt. It's just as valid to use at the mention of suicidal ideation that sometimes we might diminish because it isn't one of those, a plan or an attempt.
Yeah, no, that's absolutely true. And just saying, there's nothing better in terms of 7 randomized controlled trials, 14 open trials. So there's nothing better for treating any level of ideation. The big ding against CAMS and criticism has been that it doesn't necessarily reduce attempt behaviors, but it does, actually. There's a German inpatient trial. We saw reduction post-discharge, which is that high-risk period. And there's now data that's in current clinical trials with the campus, for example, the college student trial, where there's a signal for, there's a significant finding for behavior. But in the behavior realm, really DBT and something called cognitive therapy for suicide prevention or brief cognitive behavioral therapy are by far the most effective treatments for reducing attempt behaviors.
I had mentioned to you when we were chatting beforehand that I got a little, anyone listening maybe got a little bit of an overview of CAMS when we were talking to Kevin Curtis out of the Huntsman Crisis Center in Utah. And, they have just one thing that he mentioned, and I'll link that episode in the show notes. But one thing he mentioned is that they have a lot of collaborations going on with the law school, with the dental school at the University of Utah. And so when we're talking about just a marriage that makes sense, when CAMS is really exploring those drivers, and they have some easy access to things that could help some of the drivers that they're hearing people come in crisis stating they need help with.
Yeah. I mean, the thing about, one of the virtues I would say, it's not for everybody, but there's a flexibility to the approach and a way that it can be adapted and used and tried with everybody. And because we don't know a priori before the fact, what anybody's particular driver is going to be,
Yeah.
or what treatment they necessarily are going to respond to, that I think that flexibility or being non-denominational actually helps with the clinicians that are exploring it and maybe aspire to use it.
Yeah. Okay. Let's talk more about them. For the clinicians exploring it and that are feeling interested in the research, maybe the first piece of this question is where can someone go today now that they're curious and want more information? What's a good first step?
It's very soul-serving. There's a third edition of the Guilford Press book called Managing Suicidal Risk, and that's the source text. And there are, I think, experienced psychotherapists that can get that book, read the book, copy out the forms. We have fillable PDFs that they're working online, and give it a go. I mean, literally, there's that kind of learner.
Yes.
That can absorb the content and has sort of the mindset that, why wouldn't we do this? Give it a go. But a more traditional approach, which actually has really robust evidence supporting it, is to get trained through CAMS Care, which is the company that we developed 11 years ago, and that involves a online video of me demonstrating the use of the intervention with a really provocative patient, and then there's role play training that we can do online or live, and so we conduct these every month, and people from all the country around the world actually will engage in role play training where you're working through the first part of the model with a partner. We demonstrate it, and we literally recruit somebody out of the audience to play a patient. So it's meant to be very spontaneous, and we believe in the model, so we always do it that way. All the videos that we shoot for training are not scripted. They're actually not patients, but they're clinicians who know these patients. They're playing really well.
Yeah.
So people think they're actual patients, but they're not. But that's been really a secret sauce element to what we do, is that the video training and the supplemental trainings that we have seem like they're the real deal. And then there's consultation. So I can just say, as someone who teaches ethics and does a lot of risk management workshops and so forth, that consultation is a crucial ethical and clinical requirement that oftentimes clinicians just are too busy to do. But in the integrated training model I'm describing, Lorraine, it's you get the content, you get the role play training, you get the consultation calls, and we coach you on through the whole model, ideally working with the patient, but you also learn from being on consultation calls with other people. And those are conducted by CAMS Care every month as well. So, and then so that would be CAMS trained. So that's the sort of like, you got all the essential ingredients in the integrated model. And then for people that do it and like it and get the bug for it, they can come CAMS certified, which means they meet with a CAMS Care consultant who's an expert, and they role play and demonstrate their competency. And so, to me, I just wrote about this in a autobiographical thing. Part of my sort of true story is that I'm terrified. I was terrified of this topic, and I'm counterphobic. So there was a piece of me that just couldn't really bear the idea of losing someone to suicide, and it didn't make sense to me to say, well, I just won't work with that person. How do you do that exactly? So,
especially when any person can become that person. So how do you predict when your client is now someone who's experiencing suicidal ideation, like the 16.9 million people that you mentioned?
Exactly. So in my counterphobic style, I became an expert, and in becoming expert, I've become much more sanguine about what I can do and what I can't do. But what I can do is a lot. And, if you just look at the clinical trials we've done over 20 years, I think it's 1,400 patients that we've worked with, and we've had 5 suicides. And so our heart breaks whenever there's a suicide, but we're dealing with the highest risk populations, people coming out of the hospital who've just made an attempt, and we're able to, help the vast majority of those folks. So the piece I would love for your folks watching to appreciate is that you can move from a place of fear and avoidance to a genuine sense of confidence and competence. And when the client or the patient experiences you like, we've got this, I know how to treat this, it absolutely changes their brain chemistry. We call it a placebo effect, but placebo effects are our friends. And instead of me like frantically trying to find a bed and get rid of this person, to say, I would really want to work with you. I think these problems are treatable, and I'd like to do an outpatient basis at all possible, to really, to make this something that you look back on 10 years from now as a low point in your life. And now you get to have this life that you actually want to live with purpose and meaning.
Yeah. So it looks like from the offerings that are online, that there's the brief model that you mentioned, the training in the brief model that's for inpatient, and essentially maybe people that will see their clients in the short term, one time. Yeah.
I'm actually, I mean, they could do another session or two, but we have a new training. I think it's coming out anytime. That's just on the CAMS BI model. And we're studying like crazy because we just have one publication, but we're going to have more along the way. And, to that end, there's another model that we're really excited about called Empath units. I don't know if you've heard about this. Empath units are like the remedy for the busy, chaotic emergency rooms and emergency departments where people just go and get boarded and just get triggered and traumatized and elope and all kinds of bad things. Empath units are meant to be a separate space where very comfortable chairs,
lower stimuli. Yeah.
Yeah. Bring all that environmental stimuli right on down. Staff are trained not to yell at patients, things that, that make it a much more pleasant experience. And they hang out for a day or so and they're better. And then what we've been doing is trying to partner with these folks to say, let's use CAMS brief intervention while they're sitting in their comfortable chair for a day or so. And what we know from the one published study is that we can reduce the stress significantly, and they have an increased motivation to live one session. And that study was conducted at LSU in Baton Rouge by our colleague Ray Tucker and his student Nick Oki Frost, and 100% of the providers were graduate students. So there's a way to responsibly expand the workforce by working with social work students or LPCs or psychology students or residents in psychiatry, whatever discipline, to appropriately train and supervise them. And now you've got this like massive workforce that's doing something that patients actually like. And they walk out with a stabilization plan and clarity about the two problems they need to fix to save their lives. And if the disposition's handled properly, it's been a game changer.
Also from the training, and this will link to what you're saying, an individual can train, or it looks like you can add seats for a team to be able to do it if a facility wants to become a CAMS trained facility.
Yeah. So it's really meant to be a menu approach to training. And there's also huge discounts for people that are working in educational systems. So like if you're like director training in a clinical internship or a placement for grad students, to really discount that, because really we love training young people because they don't have attitude. They actually care about the evidence and they just want to be effective.
And they take it with them throughout their career, like the car sale, the cars that want to sell to the new grad student, the new graduated student.
Yeah. Yeah. We have a former student at Eastern Kentucky University, Melinda Moore, who's in a PsyD program, and they have a clinic, and you have second and third year PhD or PsyD students who are expert in using CAMS, and they're excited to see people who are suicidal. And, and then they go out into the world and, and spread the word. And so in the clinical trials that we've been doing since COVID, really, we've moved from primarily licensed providers to students in training. And I love working with students.
Yeah.
Because they're just so interested in being effective and competent in something that a lot of clinicians are terrified of.
Yeah.
And so they're a second or third year doctoral student or master student, social work, LPC, and they're really good at this. And it's a really interesting way to flip the script, because a lot of providers are like, oh, we have to get a real doctor involved. Let's find a psychiatrist. And frankly, honestly, again, this is data. Most psychiatrists know very little about working with suicide risk. And so it's just not in their training model. It's not in psychology's training model. So most of us that went to graduate school in mental health and across disciplines, less than 23% get even an hour on the assessment treatment of suicide risk. It's crazy.
A couple of things that are coming to mind. One, I've seen that some states, when people are renewing their licensure, they have a requirement that you do a certain number of hours in suicide training. I know Alaska is one of them. And so this could be a great opportunity, I guess, is what I was thinking.
There may be 8 states at this point. Just like we get specialized training in ethics.
Yeah.
And LGBTQS, topics, different topics that the licensure boards are really reluctant to do that because they want maximum degrees of freedom. My argument would be these are the fatalities of our field. Why wouldn't you get specialized training in this?
Yeah. Yeah. Randomly, but is there a link between those 8 states and their levels? Are they having a lot of suicidal completions?
It's a good question, but no, not that I know of.
Okay.
It'd be a great study to do, and be a great study to do.
Yeah. Okay. And I wanted to delve more into the interns, and you covered a lot of this, but I'm thinking of sites that maybe, I have one in mind actually, but a site that maybe everybody gets trained and then they have new interns joining at all times, as sites do. Do you recommend that? I guess it just depends on how thoroughly that site is able to teach or help to support that new intern in CAMS once they're proficient themselves.
It's a tricky thing. Everybody wants to train the trainer model. Which again I get, but that's a pretty much guaranteed way to lose your fidelity. So what we've tried to do is to create training hubs or places where they have a lot of people cycling through to develop internal trainers that are under the umbrella of CAMS care. And it's not so much about the money, because any amount of money that we make, we just pour right back into the business. It's more about quality assurance and making sure that folks are using the intervention as it's been designed and as the research supports it. And so we have different locations in the U.S. Where we have like internal trainers quarterly, to kind of be updated on things. And then we have folks in hubs around the world, actually, that like in the Netherlands or Denmark or China or, different spots where people are really trying to, England, there's one where people are just really trying to, be true to the evidence and to use it in a way that's effective.
Wow. That's
cool.
Great. It's great to hear that you have that awareness that's occurring in other countries as well.
Well, there's not a lot of competition.
Yeah.
I mean, if you really care about the evidence, you've got a handful of interventions, and then a number of those interventions don't have training companies. So I don't mean to be glib about it, but it's to bring something that actually works to scale is not nothing. And so that's where the business piece comes in. And in our field, it's like, it's business making money, but
exactly, it's
really a necessary evil or a necessary reality if you really want to scale something up to get people to use it. And what's interesting about CAMS is that it holds up pretty well at the international level. There are, of course, cultural things. There are things that are unique to different cultures. But because the whole thing is meant to be flexible and modifiable, we can accommodate.
Yeah, that's really neat to hear. Is there anything that I haven't specifically asked about that feels like it could be valuable to share more on?
I think we've covered a lot of ground. What I would say is we have pretty good evidence that we can do this online and not lose the intimacy or the collaborative, empathic spirit. If we use the fillable PDF of the SSF and then the provider, I'll fill it out and we'll share our screen. And then you can correct me if I get it wrong. And patients love to correct the clinician when they get it wrong. Go figure. And then a big thing about CAMS is transparency. So you always get a copy of your SSF. Clearly get a copy of your stabilization plan. That's important. But you always get copies for every session of your SSF. And that's really meant to be sort of like we are really transparent. How many times do you go to a doctor and they're like behind a laptop or they're writing something, you have no idea what they're writing about you. And in CAMS, you kind of pull away the curtain, sort of say, hey, this is what we're writing and what we're saying. And you're a co-author of your own treatment. And what you say, carries the day. Well, I'll tell you, because we're so immersed now in trials with teens, is that, I have so much to say about this, but we have 3 trials now with adolescents and older teens. And we've never before in my research life have seen like social determinants, the earth is dying, the thing I alluded to before, that as drivers or reasons for dying. And that's really striking to me. We also find that with the minors that we're studying, that we need something for the parents. And so we have a new tool that came out with the 3rd edition of the book called the Stabilization Support Plan, which is a very clear sort of set of marching orders for making sure the home is secure of lethal means. And then what can the parents do to support their child in this treatment? And that has been really powerful. When that works, it's really powerful. And then what's interesting about CAMS with adolescents is that psychologically, they're the experts on everything, especially themselves. So because CAMS is kind of like what you say, Lorraine, is what I'm going to follow, we find that the teens really take to it very quickly. And for me, for the first time, I don't know for you what's best for you.
Yeah.
I was in a consultation with this 10-year-old, and I'm saying, what I want to do with this child is give them a range of interventions to treat these issues, these drivers, and have them pick.
Yeah.
Because I really want to instill that, your parents don't know what's best for you. I don't know what's best for you.
Yeah.
And in that regard, what I would say, maybe as a closing thought, is that we're really pretty much leaning into the use of values clarification, like from ACT.
ACT, yeah.
Right? And then committed action based on your values. And then we have a colleague in Brazil, Elian Santos, who's a really thoughtful guy. He's a logotherapy, Viktor Frankl, existential psychotherapy guy, who's got this really cool intervention that's very existential. And the amount of existential struggle that we've seen in teenagers and college students has been striking. And I think we're really learning a lot and really trying to develop some thoughtfulness around that, because, and this is like where the values clarification work is so powerful, is that everybody can pretty much articulate values. Even like a grumpy 17-year-old teenage boy who like grunts, given the chance, they will tell you what actually they care about. And the treatment that can embrace that and operationalize that, and people feel better. And a big thing about that, we don't have to eradicate a driver for somebody to get better. We just have to make a dent. And if we can do that over 3 or 4 sessions, we're looking at resolution, because they're more stable, they're able to manage the thoughts and feelings, and we've opened up the door to the pursuit of a life worth living and purpose and meaning.
Yeah, that sounds great. It really resonates what you're talking about with adolescents. The developmental stage lends itself to that need for autonomy. And so to be able to have a framework that really leans into that, rather than what we always want to do with kids is strip away stuff so that we can feel like they're contained, but really continuing to give more of that.
Or focus on the parents. I mean, when we got the big NIMH multi-site, we had with some of the researchers in one of the sites a very vigorous discussion that we would that we're not going to have backdoor conversations with the parents.
Yeah.
And we want, especially like lethal means discussions, to occur in front of the child. This one person was like, but we don't want the kids finding out about, lethal means in the house that they aren't aware of. It's like, do you know kids? So we negotiated out a deal that I think we're pretty satisfied with, which is we have that initial discussion before we meet with the child, with the parents. We set expectations and we clarify what this is, answer their questions. But what we want from the parents is to secure the home and support the treatment. But this is a child-focused treatment. And if the driver is that, is communication because your mother doesn't get it, we might bring mom in. but we don't, as many interventions do, like attachment-based family therapy, great intervention, but it's fundamentally based on the idea that the family is the thing to treat. And with a lot of kids that we see, the family's fine. It's really focused on their peers and on their future that feels uncertain. So instead of kind of knowing for the patient, we kind of follow the patient's lead and collaborate to support them in that way.
Yeah, makes so much sense. So I just wanted to recap that you mentioned that training facilities, there might be an opportunity for them to have a discounted rate. I noticed too that you guys do some work around grants, and you have some support for people or facilities that may want to apply for grants.
Yeah. So, I mean, a lot, especially in the last year with some of the...
Yeah, there's the grants are...
Yeah.
The well is drier.
Yeah. Oh, it's much drier.
Yeah.
So we've had to make some adjustments, there's still funding and foundation money out there, but the pipeline from the federal government has been significantly impacted. And so, I think what the folks listening can count on is you contact CAMS Care. There's a menu of options for different learning styles and different needs. We'll negotiate, deals, especially with systems of care or a group of clinicians. And that if you're in a training setting, we can discount things significantly to really bring that next generation up the way we would want them to practice in this way to make it work. And so it's a very cause-oriented organization. We do a quarterly webinar that's free. It's online. We've had major luminaries in the field that present, and we really are. It's not just about the money; it's about the cause. We have to pay the bills, but at the same time, I think it's pretty clear by our mission statement, by the way we think about this, that we're really trying to move the needle on people that suffer to save lives therein.
Yeah. All right. Well, thank you so much. I've got to ask you the final question I ask everybody. Do you have anything that you think about when you think of self-care, anything that you do or anything that you like to recommend for clients?
Well, I love that you do this, and I love the name of your podcast.
Thank you.
Yeah, I spend a lot of time with my wife.
That's
she's
good.
She's like my best friend, and I think, have a pretty regular way of like connecting and supporting each other. I'm a big believer in psychotherapy. I did 5 years of therapy in grad school, and really believe that we should practice what we preach. And I think consultation and having like key colleagues that really get it. I mean, even though I know so much about this topic, when I'm seeing a person that's suicidal, I would never be a lone ranger. I would still talk to Abby Mandel or Barry Wagner, colleagues at Catholic, the people that I know that really know me, because it's just really good. Two heads are always better than one.
Yeah.
And I think it helps with burnout, and it helps with clinician self-care. And then doing things that are effective actually is great for morale.
Right. I was thinking that about grad students too, that to have a framework that is effective and that you can learn inside and out, not everything fits for that. But I think that just sense of mastery and autonomy, again, could feel really good. So
it's been interesting in the emergency departments and places where we're developing like CAMS clinics and so forth. Hope Institute, how excited clinicians are because they're actually doing something that works.
Yeah.
And that gets infectious. And so, the Hope Institute, people come in, they think, oh, it's going to be this place that all they do is work people that are suicidal. It is, the culture and the spirit is one of hope. It's one of we can do this. It's one of we got you. We're not going to invalidate you. We're not going to shame you. We're going to honor you. We're going to hear and listen. The parents and families feel better. The patients feel better. And that's a very different kind of way of being experienced versus like, I got to get rid of you. Where can I find a bed?
Yeah. Great closing thought. Yeah. All right. Thank you so much for your time today.
Appreciate it, Lorraine.